Welcome, everyone. My name is Lori Hutchison. I'm the Executive Director of the Lobular Breast Cancer Alliance and also a patient advocate. And I want to welcome all of you today to this discussion of the pathology of invasive lobular carcinoma. And I want to thank you very much for helping to move the dialogue forward on this issue of standardizing the pathology. Let me just share the agenda for this discussion. After I introduce our moderator and panelists, Dr. Metzger will moderate the discussion of the issues related to the standardization of the pathology of ILC, and then the discussion of what's next. How do we move this forward? Our moderator, Dr. Otto Metzger, the LBCA Scientific Advisory Board Chair, maintains an active clinical practice in the Breast Oncology Center at Dana-Farber Brigham and Women's Cancer Center. He is also a clinical investigator focused on the development of therapies for breast cancer treatment. His principal research effort is focused on investigating two subtypes of breast cancer, invasive lobular carcinoma, ILC, and HER2-positive breast cancer. Dr. Christine Desmedt has bioengineering degrees in cells and genes, biotechnology, and biomedical sciences. She received her PhD degree from the Breast Cancer Translational Research Laboratory, Jules Bordet Institute, and is now heading the lab for translational breast cancer research at the KU Leuven in Belgium. She is and has been devoted to research on invasive lobular carcinoma for many years. She is also the co-chair of the European Lobular Breast Cancer Consortium, LobsterPot. Dr. Anne Vincent-Salomon has been a pathologist since 1993 at the Institut Curie in Paris. She coordinates the Pole of Diagnostic Medicine and Theranostic and has been head of the pathology department since February 2015. She holds a PhD in molecular and cellular genetics in oncology. Her research includes the description of the morphological and molecular heterogeneity of the histological types of breast cancers, as well as a focus on the tumor progression of disease in situ to the infiltration disease. She is also a member of the European Lobular Breast Cancer Consortium and LobsterPot. Dr. Jorge Reis-Filho is an LBCA Scientific Advisory Board member as well. And he is a surgical pathologist and chief of experimental pathology at Memorial Sloan Kettering Cancer Center in New York. His research interests are in the development of a predictive breast cancer classification system based on the oncogenic drivers of special histologic types of breast and salivary gland cancers, and in the understanding of the causes and impact of intratumor genetic heterogeneity in cancers. So without further ado, I will turn it over to Dr. Metzger to kick off this discussion.
Thank you so much, LBCA, for putting this together. I think that the diagnosis of lobular carcinoma is a very hot topic. It's needless to say that this house believes that diagnosing the histological subtypes correctly is very important for our clinical practice. LBCA believes that we should study lobular carcinoma as a separate disease subtype, so a correct diagnosis is very relevant. I am, as an oncologist and not as a pathologist, I'm thrilled to have such a fabulous panel today to join this conversation about the diagnosis of lobular carcinoma. I think this is going to be a very interesting discussion. I don't have much to present, but I have a few slides that I would like to share from a recent work that we've been doing and in collaboration with Christine, who is here on this call, which basically look into the data from a very large clinical trial, a study conducted in Europe, the MINDACT study. And on this exercise, what we tried to do is to go back into the study and understand what has happened for patients diagnosed with lobular and ductal carcinoma. And I think that this has some interesting messages here. And MINDACT is a study that prospectively had a central pathology review of histological subtypes for all samples that were included as part of the study. So for all patients enrolled into the MIND-ACT, a sample was sent for genomic profiling for the MemmaPrint test. But the investigators were very clever by doing a central pathology review for histological assessment, and this was done by a very senior and knowledgeable pathologist in Milan, Dr. Beppe Viale. And I think that here we have some interesting messages. When we look at the diagnosis of invasive lobular by local calls, by the way each pathologist in each hospital in many countries classify the lobular, and we cross-tabulate against a central review of histological subtype, we see a fair amount of discordance. So this definition of lobular, it seems not to be so black and white, and I think there is a space for us to improve on that, and this is going to be the topic of our discussion. And on MIND-ACT, very briefly, this is important because when looking at the MemmaPrint, we saw that 16% of these cases were classified as high risk. This has relevance to prognostic assessment and the way we evaluate patients diagnosed with lobular carcinoma in the clinical practice. But what was really interesting here is that when we divide lobular carcinoma in what's called classic invasive lobular carcinoma, we see that the distribution of genomic risk was different. The percentage of patients with high risk was smaller, was 10%. But when we look into the non-classic variants, which are rare variants of invasive lobular carcinoma, the distribution of genomic risk was also different. So here, the message is, I think that classifying lobular correctly, it's going to be important for our clinical practice. And even this distribution or this classification of what's called an invasive lobular with classical features versus variants could also be important, because as a clinician, if I have a diagnosis of a variant of invasive lobular carcinoma, let's say a solid variant or a pleomorphic variant, in my mind, I could say, well, maybe this type of cancer could have a higher risk if we had a genomic classifier. And these things are very important when we try to make decisions for patients diagnosed with early stage disease. So I'll stop sharing here, and moving forward, we're going to have Christine Desmedt. She's going to talk a little bit and show some slides touching base on these issues, followed by Dr. Vincent-Salomon, and we're going to kick off with an interesting debate about all these topics.
Okay, good morning or good afternoon to all of you as well. So actually, it's a great pleasure to be here to discuss this very important issue all together. So I'll just continue on what Otto has been telling us. So the fact, and we all agree here, as he was saying, that we need to have a harmonized pathological diagnosis for lobular breast cancer. This is really needed. And he gave the example of the discordance that can happen between local pathology in the local hospitals versus centralized revision of this diagnosis. And he has actually shown what happened in the MIND-ACT trial, that actually, if you consider local pathology, actually only 60% of the locally diagnosed lobular cancers were confirmed centrally. And this is not an isolated fact. Actually, this was also true in another large trial, which was carried on in Germany, where the same happened, actually, that only 66% of the lobular cancers that were diagnosed locally were actually confirmed by central pathology. So I think that this clearly sets the scene, because if we want to move forward, if we want really to recognize lobular breast cancer as a separate entity, we first need to have a harmonized definition. Next. So another fact that I want to tell you is that to really get a better agreement, a better concordance in diagnosis, there we actually have one tool. It's just that it's not been used and not been set in the guidelines so far, because the guidelines that are used so far are the guidelines by the World Health Organization. It's called a Blue Book. There is where all the rules are set for pathologists to look at the minimum criteria that are needed to define some subtypes of diseases. And so far, for lobular breast cancer, it's sufficient just to look at a slide through the microscope and to look at the, no, please go back, and to look at actually the what's so-called the histology. However, this very recent study that has now been accepted in the Journal of Pathology and that has been led by a brilliant pathologist, Matthias Christian, has actually shown that the concordance between different pathologists is strongly enhanced when, in addition to the standard, what we call hematoxylin eosin slide, which is used for all cancers, when in addition to that, we use a slide that we color for a specific marker for these lobular carcinomas. And when that is used, then the what we call inter-observer, inter-pathologist agreement is much higher. So this is also something to consider. Next, Lori. Based on that, we thought that before setting, harmonized guidelines, it's important to know what is happening so far in the world. So how in the different hospitals in the US, in Europe, in Asia, in Australia, in South America, in Africa, how is it so far happening? How do pathologists report on the diagnosis of lobular carcinoma? So to do so, it took us really some time because we wanted really to be sure to reach out to pathologists, not only from the largest, the most prestigious institutions, but also to reach out to smaller hospitals, to private and public hospitals, so that we could have a good representativity of all the pathologists and all the different practices in the world. So this was an initiative that was led by our university, our group, but also from the pathology working group from the European Lobular Breast Cancer Consortium. It's maybe from the European Lobular Breast Cancer Consortium, but here I want to insist on the fact that there was a strong collaboration with the researchers and also pathologists in the US and in other parts of the world. So globally, nearly 150 pathologists participated from 34 countries over the world, and they have reported heterogeneous diagnostic criteria and procedures for diagnosing lobular breast cancer. And also, they have reported a variety of antibodies that they use for icadirin, which is the specific marker that we want to use to assess if it's a lobular breast cancer or not. Next. So this is to tell you actually all the countries where we had responses from. So next, Lori. And so just to give you some highlights, actually, while it is not mandatory so far, actually half of the participants report the systematic use of immunohistochemistry for this icadirin for diagnosing lobular breast cancer. 45% report only to use it in case of doubt, and then a minority only performs immunohistochemistry for the in situ disease. And what we also interestingly noticed is that there was no association between the systematic use of immunohistochemistry, the volume of the breast cancer samples that are examined in the hospitals, so that there is no difference whether it's a very large hospital seeing many breast cancer patients compared to smaller hospitals, or to the type of institution, whether it's a private or a public institution. Yes, so if you would like also to know more about that, we will be presenting our poster also at the San Antonio Breast Cancer Symposium next week. Yes. Laurie? Yeah. So I think also that as compared to a few years ago, we are really going forward. And one of these steps was first to assemble really people wanting to move forward on lobular breast cancer research. This is what was done, stimulated by patient advocacy on the US side by LBCA, and this is fantastic. And this is, and on the European side, we were assembling together with Patrick Dirksen and Vincent-Salomon, who is here today, we were assembling this European Lobular Breast Cancer Consortium. It's a bit different from LBCA because there it's more driven by scientists and clinicians together with patient advocates. So here in this ELBCC consortium, we have a dedicated pathology working group, which is led by Vincent-Salomon and Matthias Christian. And here, many members also from the EU countries are participating, but it is also open for pathologists and researchers outside of the EU. And we have several dedicated meetings and studies to move forward with this. And one of the aspects we want to do is first to gather the evidence of why we need to recognize that we need to have harmonized guidelines before coming with these guidelines. So this was my last slide. So thank you, Laurie. I know my last, sorry, this is my last slide. Apologies. So the conclusion of these few slides is actually that we see an important discordance between local and central pathology for ILC diagnosis, that central pathology is important when performing retrospective analysis of large clinical trials and also when including patients in these lobular specific trials. And these trials are really starting to emerge. Also, the survey that we did, I think, describes importantly what is currently being done in the world and the heterogeneity that we see there. And we really need homogeneous criteria to be established. And we really want to move towards a morphomolecular, a histomolecular diagnosis of lobular breast cancer. So thank you. This was my real last slide.
Thank you, Christine. I think that this is excellent, and it set the stage for very interesting conversations about the proposal to move to the morphomolecular diagnosis of ILC. I believe that Anne has a few slides, so I'll let her go forward and we're going to kick off the discussion.
Thank you, Laurie. So, in fact, to go even into more details and to make clear that lobular carcinoma represent again a spectrum of disease, and pathologists have also to work on a better identification of the variants of lobular carcinoma to be sure we don't miss any lobular carcinoma. And in fact, in this blue book Christine just mentioned earlier, we have a definition of variants of lobular being either variant because of special architectural and growth patterns, the alveolar, the solid, the tubulo-lobular, or because they have cytological differences and cytological patterns with the pleomorphic, the histiocytoid, and the signet ring cell. Next. So why is it so important to better understanding the variants? First of all, the Blue Books reports the 6 variants I've been mentioning before, but in fact, in literature, pathologists have been describing like many variants, and also an additional complexity, level of complexity is because in many cases, variants are associated together to form a mixed variants into a single tumor. Christine and her group has made very clear that at the molecular level, some variants are associated with different molecular alterations. So we need to understand if to take these variants into consideration makes a difference in terms of response to treatment in dedicated clinical trials. Next. So just to have examples and it's not to get into the details of the morphology, but here we have the three most well-recognized cytological variants of lobular carcinoma. One that can be very difficult to diagnose for pathologists if they are not aware of the existence of this cytological variant, the histiocytoid subtype. The pleomorphic is probably the most well recognized by pathologists, but the definition can vary from one pathologist to another. And it's generally recognized because the nuclei of the tumoral cells are bigger than in the classic lobular carcinoma. And another cytological variant is really important to know is the signet ring cell, because we are all aware that the lobular carcinoma can metastasize to the gastrointestinal tract, and within the stomach, there is a special carcinoma of the stomach composed by signet ring cell. So in a woman, if pathologists ignore the existence of cytological variant, signet ring cell variant that can exist, it can be confusing. Next. So these 4 examples to illustrate the architectural variants, the solid one, the solid papillary, very recently described by Matthias Christgen in particular, the alveolar variant, or the trabecular variant. Next. And to make even more complicated the situation, we know that lobular carcinoma are composed by isolated cells, but some of them can have tubes within the tumor. And it is now better recognized that lobular carcinoma with tubular elements are associated with a different phenotype that can help the pathologist to recognize them. But once again, it is not clearly written in the Blue Book. So we don't have very clear rules. And so there is a need to define properly these entities. And also, pathologists recognize mixed lobular plus ductal carcinoma mixed together. And the frequencies of these variants are also very different from one study to another, illustrating the fact that pathologists maybe do not recognize pretty well the association of ductal and lobular sometimes. And it's of course important to recognize a component of lobular carcinoma because of its of the possibility of a different metastatic pattern associated with this component. Next. So in conclusion, it's really time to improve the recognition of the lobular carcinoma as a morphomolecular entity. So we are all working on that. And also we need to standardize the way we use e-cadering staining. So the best panel to recognize the different variants of lobular are also to define, and the best clones, because we have a lot of antibodies available in the market. So we have to work on that to be sure we make the right diagnosis for the right patients. Thank you.
Thank you so much. I think that it's very interesting. And for me as an oncologist and not a pathologist, it's mind-blowing to see how we're able to differentiate all these images. And and I think that it also explains why there is a fair amount of discordance given the challenges, and not everyone is an expert in the field as a pathologist to recognize all the subtypes. And even in my institution, sometimes in our reports, we don't get all the granularity information. Sometimes maybe because not everyone agrees that the variations are so important for us while making decisions. So I want to kick off this discussion with a provocative question, maybe to George. So if we believe that we should move from a morphological diagnosis to a diagnosis where you have some additional tests, do we really need that for all cases? Or as a pathologist, sometimes you look into just the morphological characteristics and say, well, this is a classic lobular, and I'm fine with an H&E for a diagnostic call, and I don't need any cadherin staining, for instance.
Otto, I dislike profoundly the idea of one size fits all, even in pathology. We need standardization of criteria, and we need to provide a system by which pathologists in the whole world can render the diagnosis. So I think we need to take into account all of those parameters. That's one point. Second, we have to remember that CDH1 biallelic mutations, when present in breast cancer, 97 to 98% of them are present only in lobular carcinomas in the classic and the variance, okay? However, if we go back to lobular carcinomas in Christine's paper, our papers, and TCJ as well, only a proportion of 60 to 80 something % will have biallelic pathogenic alterations affecting E-cadherin. Many more will have also E-cadherin loss of expression by immunohistochemistry, but it's not all either. So my fear of saying all cases, regardless of histology, need to be diagnosed with immunohistochemistry may be misleading in a small percentage of cases. So I think we're in the process of standardizing the criteria, and I think information coming from the studies Christine and Anne are leading, plus the endeavors of many other investigators in the US and across the pond as well, will help us standardize this in the near future. But I think my take-home message here is twofold. One size fits all may be a bit dangerous. And second, that we need to be studying this properly and systematically. One final point that was not discussed here, that is that oftentimes we see a misdiagnosis of lobular because the material is not really adequate. It's in a core biopsy that was a bit crushed, and then people, our colleagues are not comfortable, and render a very conservative diagnosis not to miss something. And we have to remember that some of the disagreements come exactly from that type of analysis.
Mm-hmm.
I'm sorry. Excellent, George. I like the idea that not one size fits all. And do you want to add anything to that?
Well, I certainly agree that the staining is not probably, the E-cadherin staining will not solve all the issues. And so we have to figure out how to best define the entity, to make sure the pathologists have a nice specimen and a well-fixed and prepared specimen to make the diagnosis. And it's sometimes challenging, we know that, but promoting a better education, quality control, assessment, etc., improves enormously the quality of the specimens we analyze. But beside the better morphology and good morphological criteria, help from E-cadherin staining. And in case you are sure the morphology is the lobular morphology, but the E-cadherin is positive, in that case, what do we have to do? So we have to go a little bit further, and to be sure, we try to figure out all the situations, at least the best we can, to improve.
And I would like to add one point here, Anne, because that's a question that we do not know yet. Is the behavior of a lobular carcinoma, classic lobular, that's E-cadherin positive and E-cadherin negative, the same? And I don't think we have had sufficient studies to address the diversity that we may end up finding in those groups. And I think, again, you, Christine, Otto, you have a gold mine of cases with clinical outcomes here that I think would justify a focused study for us to understand whether there are any biological differences. Because we know, for instance, from at least in vitro studies, that the loss of icadierin results in the acquisition of anoic resistance that may prevent the efficacy of some of the therapeutic drugs we currently use. So this is only in vitro. There's no evidence in patients in that regard. So if that was the case, would there be a difference between those that are icadierin completely null versus the lobular carcinomas that are icadierin functional?
Excellent, George. No doubt this is it's a great research question. But I still want to remain on this topic just for a little bit more, because it's a real hot topic. And is it true that when evaluating icadierin loss as a pathologist, that it's harder to see the loss of expression of a marker instead of positivity? And how do you feel about this staining the icadierin P120 that makes the cytoplasm pink as a way to facilitate the diagnosis?
Mm-hmm. I think you're right. The pathologists know that if they are looking for the absence of a marker, they have to be sure we have controls within the same tumor. And to make things clear, in a cancer, especially in lobular breast cancer, we always have some normal glands that are remaining within the tumor. And so we have the controls, the internal control being positive with the positivity of the normal glands, and the negativity is very comfortable to interpret in these conditions. So of course, it's really mandatory to have this internal control before saying icadierin is negative within the tumoral cells. That's for sure. And the help of P100, the catenin stainings to help in case of lobular carcinoma being icadierin positive. It will be positive, of course, but it's more often irregular or less intense than the normal glands remaining within the tumor. So the beta catenin or the catenin, the P120 catenin within the cytoplasm is a huge help. But this is not standard at all. And not all pathologists use other marker in addition to icadierin. So that's the field we need to clarify and investigate. And as George said, we don't know the clinical behavior of tumors with these patterns on large series. So definitely it's to be done, yes.
Excellent, thank you. Those are great points. And George, you alluded to the challenges in the diagnosis once you have limited specimens, like in a core biopsy. And I'm dealing with this problem at the moment because we conducted a clinical trial, including patients with lobular and ductal, where we had to have the diagnostic call on a core biopsy because that's the way the study was designed. Had no implications to the way we treated patients, but from a study perspective, it did create some problems because it was not always so black and white for our pathologists to say that the case was indeed a lobular based on a core biopsy. And when we saw the residual pathology specimen, what was called lobular was not necessarily always true. So how difficult it is to have a histological call on a core biopsy?
It depends on how representative the core biopsies are, but I feel at times uncomfortable in rendering a final diagnosis, in particular in terms of histologic typing from a core biopsy. As Anne mentioned, mixed tumors are not uncommon. That's one point. In this biology, we're not even talking about pre-analytical parameters that impacted on our ability to render an accurate diagnosis. We're talking about biology. With a core biopsy, we're sampling an area of a tumor. Okay, so that's one. The second point, if we have any type of artifacts, our ability of histotyping a tumor is not 100%. And there will be disagreement. I think if we have the material of the excision specimen together with the core after the core. I think that the best way of ascribing the final subtype of a given tumor would be that of the surgical specimen, because we have a much greater representation. But in the core, for instance, the recommendations of staining or not staining, performing immunohistochemistry to guide the diagnosis, in particular with the cadherin here, would be a good one. Because in those cases where we have doubt, the cells look like in single cell files, but the thing is a bit crushed. We don't see any ductal formation. The cells look a bit discohesive, but we are not sure because the fixation or the processing was not optimal. Here, cadherin can be of great help, so long as the immunohistochemistry has not been affected by the same pre-analytical parameters. Because remember, if you process something poorly, it will affect histology, but it will also affect immunohistochemistry reactivity. So I think the goal here is we need to have the pre-analytical parameters as standardized as possible so that people like Anne and myself can read the diagnosis in a meaningful way. But I think if we are in doubt, using ancillary methods is always a good option, always. And then rendering a diagnosis that give us the possibility of guiding the treatment in the most meaningful way. Does that make sense?
Yeah, that makes a lot of sense. Thank you. So I want to turn out now to Christine to ask some questions about like genomic assays in lobular carcinoma. And this is a topic where I learned a lot from Christine while we were working together in Brussels many years ago. And Christine, how do you see the importance of the tumor cell cellularity in lobulars when performing these genomic assays? Because we know that lobular is with the discohesive growth. Sometimes we have a lot of stroma or non-invasive cells intermingled in between the cancer cells. And when we do these genomic studies, we're not necessarily just taking the invasive cells in itself. So how do you see this as a pre-analytical or a methodological issue when interpreting genomic studies?
Thank you for the great question, Otto. So I think there are different aspects actually to that answer now. First, I think it depends whether you are evaluating samples from the primary disease, so when the disease is still in the breast, or when you're evaluating metastatic lesions. Because when you look at metastatic lesions, and these are now often used also when it's possible, then actually there anyway, we see the tumor cellularity to be much higher. So there it's also often less of a problem. So it's true with all the studies we did, for studying primary lobular breast cancer, so when the tumor is still in the breast, that there we see, as compared to the remaining breast cancers, that often the proportion of tumor cells that you get as compared to the other cells you get in your sample is often lower in lobular tumors. However, now there's also been a lot of changes in the sequencing technologies, in the fact that actually for most of the studies, we use these targeted gene panels, so which actually study a limited number of genes. And now we can, for let's say the same price as a few years ago, we can sequence much deeper. So meaning that we can really go much deeper to look for the information. Of course, you need always to make sure that you have enough, tumor cells, but still, even then, if you have not that many, let's say, not a majority of tumor cells, you can still get, enough information for that. And I think even now also going further, and I think Jorge want to comment, even now looking further, not only on primary solid samples, metastatic samples, there is also really important information that we can get also from liquid biopsies in patients also with metastatic lobular breast cancer. Jorge, you want to comment further?
Yeah. There's one point that I wanted to add here, Christine. I agree with you that with our ability of using deeper sequencing now, coupled with, duplex unique molecular identifiers, we can go really deep. But there's still a problem. If there's low cellularity, our ability to identify biallelic inactivation of tumor suppressor genes CDH1, the gene that encodes for academia, included, it's still complex, and sequencing cannot bypass the impact of samples that have very, very low cellularity. We can still genotype them and say, oh, there's a mutation here, but we have no idea as to what else is going on in terms of copy number alterations or LOH, loss of heterozygosity. That's one point. And the second, I think, studying metastatic disease is very, very important. And the studies from many groups at Dana-Farber Memorial in Europe, I have now demonstrated, and I think Fabrice's paper in Nature a few years back shows this really elegantly, that the early drivers of the disease are maintained between primary breast cancers and metastatic tumors. However, metastatic lesions have many important differences that impact on our therapy decision-making. And in lobular, what we have seen ourselves through the analysis of our MSK impact dataset is that there is an enrichment of one mutagenesis process in lobular carcinomas in the metastatic setting. In particular, that is the ApoBAC mutagenesis that leads these tumors to have many more mutations than usual. And we've seen enrichment for some potentially targetable alterations, including ERB2 kinase domain mutations. So I find this really exciting, but there's no excuse for us not to get an adequate sample for the sequencing. There's no excuse.
Oh, excellent. And I think that these are very important points because the field is moving so fast, and now we're basically profiling samples from metastatic sites more often than before, and really trying to understand this in clinical practice. So it's a routine in the US for us to do this for a lot of our patients in the advanced setting, which is very important because it gives us information about the disease we're trying to treat at the moment. But I want to go back. I still remain on this. Yeah.
I just wanted to add something just to finish also what George was saying, is that it is super important to look at the differences also in the metastatic disease. And what we need to realize, what is really important is that now with all the different studies he has mentioned, we know that most of these differences actually are seen in patients that have these estrogen receptor positive tumors. It's there that we see the differences. And when we look to lobular tumors, we know that approximately 95% of lobular tumors are actually estrogen and or progesterone receptor positive. So it's also there for lobular patients that we expect also to have more changes in the metastatic samples as compared to the primary disease. So this is really something important to realize. Sorry, this was just an important parenthesis, I thouto.
No,
I just want to mention something. I don't know if Christine and George will agree, but to make a point that within the metastatic disease, generally, the cellularity is higher in the metastatic site compared to the primary tumor. So generally, if we document properly the metastatic site, we have enough material to study. At least that is my experience, but I don't know if you want to comment on that. Yeah.
On average, yes, but we have some lung biopsies and some bone biopsies that prove to be really hard.
I agree. Yeah.
I can imagine. So, and what about in the early stage setting when we're using commercially available genomic assays to decide to help us with prognostic stratification and help on chemotherapy decisions? So we do that often, and I usually on this commercially available reports, we don't have a granularity of information about the tumor cell cellularity that was profiled. Is there any reason to be concerned, or should we interpret these reports with a different set of eyes for patients with lobular carcinoma and low-grade disease?
Yes, so if I may comment, I think this is a very, very important area of discussion, and I think we should not blindly acknowledge that everything that has been described and developed for the general breast cancer population holds true actually for the lobular breast cancer population. And there are different aspects for that. First, none of the studies were developed specifically for patients with lobular breast tumors. So all the information we have for patients with lobular breast tumors are actually a retrospective analysis extracted from these larger trials. Also, many of the evidence that has been published is also, for example, based on the retrospective evaluation of institutional series. And if we take all the information together, we have very diverse information. We have a lot of information where, for example, we do not have follow-up that is long enough, and we know that patients with lobular tumors can recur many years after the initial diagnosis. And if the studies that say, okay, fine, this assay works fine, but only looks for follow-up of 4 or 5 years, then we cannot tell with, with a lot of assurance that it is actually okay to do so. Also, if you look at the different studies, there is a lot of heterogeneity in the characteristics of the patients that were investigated, in the treatment they received. In some studies, they didn't receive chemotherapy. In others, they received. In some, they did receive endocrine therapy. In others, only partially. So I think we still need to be extremely careful, really first in interpreting what we get so far from the literature. I also think that we should be careful not to extend the conclusions from one test to another, because there are differences also still between the tests. And then I think what you say is completely true, Otto, is that so far we do not know if the tests that are processed, how many tumor cells they were having. And since we know that most of these tests, they kind of make a big mix of all the cells that you have, if it's only a very small minority that are the tumor cells, then the information might be completely diluted. So I think here it's just a big warning still.
Excellent, thank you. So we have a few minutes left. I just want to tell you briefly what I do in my clinical practice for a test that's commonly ordered in the US. I go into the ER and PR reports from the genomic test to make sure if they are really positive, because if I have a classic lobular and a genomic result where the ER and PR subcomponents are negative, for me, what was profiled was not necessarily the invasive disease. But again, I think that the overall message here is that for us clinicians, it's very important to trust on the pathologists and establish a good relationship with pathologists for the cases that you're treating. And we should not trust on the reports from genomic assays by itself, because they can be useful and they can complement risk stratification, but they're not necessarily always the truth. So given that we have 5 minutes left, I want to ask the panelists how they feel about the importance of the patient advocate organizations, and how can we really move the field forward? What do you think that we can do as a next step? So I'm going to ask the three of you to share your opinions. And I know this is not an easy question, but we really need to make things better. So I honestly think that the role of patient advocacy for a subtype that is quite prevalent, is the most common special type of breast cancer, and it accounts for a substantial number of patients. Without advocacy, this topic will keep being forgotten by our funding agencies, by our professional societies, and so on. There's a fundamental role here that patient advocates play in bringing this to the attention of our funders, our societies, also to help us understand what the needs are in terms of research, because we can live in, I'm guilty of that. I work at Memorial Sloan Kettering, and it is as an ivory tower as it could possibly be. And I'm guilty of pursuing very interesting biological questions that may not be the most pressing needs that our patient advocates and the patients themselves may have. So I think this dialogue helps us define what the priorities should be. And I think it needs to be a real dialogue.
Science cannot only be guided either just by the immediate pressing needs. We need a balance of long-term goals where we can change the paradigm forever and addressing the immediate needs so that we can help those who need a change immediately. And I think the advocates actually are the catalysts for this type of mixed portfolio of research, clinical and translational, to be implemented.
Excellent. Fully agree.
Yes. So maybe I just want to add to this point. So I was actually, when you were asking the question before, I was actually identifying 4 different points that are actually important and really beyond also what we discussed here for pathology, also as George was saying. So I think first is to really raise awareness, because wrongly still breast cancer, like George was saying, is still saying as one common entity, you know, and people do not see actually that it's a multitude, you know, of different subtypes. So it's just that one name, but actually there are many different entities, and lobular breast cancer is one of those. I think another important role that patient advocacy has, and with solid organization like LBCA and like what we're trying also to build in Europe, is really there's a mission to share correct information, because there are too many patients being wrongly informed, just going anywhere on the web and then coming with wrong information. So this is also, for example, why Lori with LBCA and we with the LBCC, we try to develop correct information, leaflets also that we try to translate in so many different languages so that people get the correct information. But I think to stimulate the sharing of the correct information is also very important. Then I think also, it's important for patient advocates to really identify, you know, what for them are critical issues to be, to be looked at, and on which we should do research, and to keep hammering on that. And then we get it, you know, we started working several years ago already with several patient advocates, and it's important, you know, to know that what we do has a meaning for the patients. Unfortunately, sometimes we need different steps before it really has a meaning, but yeah, that's a point. And then also really it's important because I think that patient advocates are really the glue, the link, you know, the connectors between the very wide patient community and between the community of clinicians and researchers. And that's important, you know, because before being able to do the dialogue as we do now, we need to get each other. We need to understand the language that we are speaking on both sides. But it's important to have this constant link, the glue actually between two. So I think that's, and there are still many other reasons that we were also describing in our paper, but that's the main reasons.
And if I can add a small word, I completely do agree with what George and Christine said. And I think that in Europe, we are very far behind what American patient advocates are doing. And this is really fantastic. You are also a source of inspiration, I think, for patient advocacies in Europe. And we have another difficulty. Christine, you said that we have patients and physicians and researchers to speak the same language. But in Europe, we have, in addition, and on top of that, the problem of languages across Europe. And we try in the ELBCC to be sure that patient advocates from Spain, France, Italy, may join the ones from England, the Netherlands, Germany, etc. So we have a hard task to finish, but we are really motivated to do it, because I think that as a pathologist, we don't see on a regular basis the patients, and for the researchers, it's the same. And it's really inspiring. It gives us energy when we see and talk with patients, because you make us feel that we are on the good direction, on the good path. And so together we will beat the cancer. I'm convinced of that. Yeah.
Excellent. I would like to wrap up by thanking LBCA and the panelists that have joined. I think this was a fascinating conversation about the challenges that we have with the diagnosis of lobular. I think that we highlighted important points in important areas for research. And I want to finish by saying that I really expect that these two fabulous research organizations or patient advocate organizations, the LBCA and the LBCC in Europe, will continue to work together and try to find synergies and collaborations so we can tackle the important questions and hopefully come up with strategies that are going to improve survival for patients diagnosed with lobular carcinoma. Thank you again. It was my pleasure to be with you this morning.
Thank you.
Thank you very much.
Thank you.